So thank you for giving me the opportunity to talk about prostate brachytherapy and specifically talking about the technical aspects of prostate brachytherapy. I'm a professor in the Department of Radiation Oncology, and I'll spend about 15 minutes going over some key points about prostate HDR. And when we go over prostate HDR, some of those techniques and procedures can also apply to LDR as well. I have no disclosures. So just to give an overview, I'll talk about the clinical evidence for prostate HDR. We'll talk about patient selection, including
just hold, Dr. Khan, please. Just readjust the sound system, please.
Okay, it was with the sound. Is it not working? Oh, can you hear me?
We hear you, but the sound is not clear.
Okay, I'm not sure. I think on my side, it's hard
okay.
to know how to clear it. Hold on.
Now it's okay. It's okay.
It's okay. All right.
Now.
So we'll talk about. It's okay. All right. So we'll talk about inclusion and exclusion criteria. We'll talk about some of the technical aspects, including the equipment that you need to have, including the implant procedure itself and the techniques to implant the needles. We'll talk about the treatment volume, like the CTV and the PTV, and to getting good coverage. We'll talk about some of the planning games, dose constraints, and then the quality assessment post-implant and how to sort of manage that and what's considered acceptable. So what is the clinical evidence? Like, why do we do this? So there's at least probably the highest level of evidence we have is a phase 3 randomized trial that looked at external beam radiotherapy, where in this study they gave 55 gray in 20 fractions external beam. And this was compared against another arm, which was given external beam 35.75 in 13 fractions, followed by a brachytherapy boost. And during the brachytherapy boost, they had gotten 2 implants of 8.5 gray in 24 hours. This was done in 1997 to 2005. They had 218 patients. Half of them were randomized to an external beam radiotherapy, and 110 were randomized to the boost arm. And this was a balanced one-to-one randomization, and these were randomized based on stage, PSA, Gleason score, and adjuvant therapy use. And the stage, so patients that were eligible included patients with T1 to T3 prostate cancer. They had to have PSA less than 50, and they had to be able to undergo anesthesia, and they were appropriately staged so that there was no known metastatic disease at the time of randomization. So in this phase 3 randomized trial, as you can see on the top right up here, the patients that got external beam radiotherapy and the boost had a higher relapse-free survival, and it was statistically significant compared to those that got external beam radiotherapy alone. And the findings were that there was a 31% reduction in risk of recurrence, and then the 4-year median time to relapse was 116 months, which was longer in the external beam radiotherapy in the boost arm versus the external beam radiotherapy alone arm, and that was only 74 months. And there was no difference in overall survival. And when they looked at the toxicity, they found the urinary and bowel toxicity endpoints were equivalent in both arms. And there are many, many other sort of smaller level studies, maybe not a phase 3 randomized trial, but other sort of single institution prospective studies that have also shown pretty acceptable, biochemical relapse-free survival from low risk to intermediate and even high risk prostate cancer patients. And they've had acceptable grade 3 and 4 toxicity. The oldest study was in 1997 by Brachytherapy, and then studies have gone on since then with various years with a larger number of patients and varying HDR doses. So if you're going to do prostate HDR, what is the inclusion criteria by which patients are eligible? Number one, once again, is stage T1B to T3B. They have to be biopsy-proven prostate cancer. Pretty much any risk patients is eligible. But however, most places will tend to say, the very low risk prostate cancer patients are either going to get surgery or they get external beam. But really, they use a high dose brachytherapy is mostly for intermediate and high risk patients as a supplement to external beam to dose escalate the prostate. Any Gleason, any PSA are eligible as long as they're not metastatic. And also, people talk about the prostate gland size. Historically, 60 cc was a cutoff when people did like LDR. But even LDR, actually, there's several institutions, especially where my own institution, that 60 cc is kind of more based on technical capabilities. But people have implanted larger glands as well too. So prostate gland size is really not a contraindication as long as you're comfortable, you have more experience, and you can. So gland size is not necessarily a contraindication. And also, you could use androgen therapy to try to shrink some of the gland down before you do prostate brachytherapy. You want to have at least a minimum distance of 5 millimeter between the posterior gland margin and the rectal mucosa, but it's not an absolute contraindication. But that 5 millimeter margin between the prostate posteriorly and then the rectum is so that the dose can drop off, and you don't have to, and you can meet your constraints for the rectum. You do want to avoid direct contact of the posterior catheter with the rectal mucosa. What is the exclusion criteria? So if they had a TURP within 3 to 6 months, those are ineligible. If they have a urinary flow obstruction, so the Qmax is less than 10 milliliter per second, IPSS greater than 20. If they have a lot of pubic arch interference, you're expecting that you can't put the needles in. It's going to interact with the pubic arch. And even then, that's a technique issue where if the patient in the dorsal lithotomy position, you can pull the legs back and open up the pelvis a little bit. But pubic arch interference can actually be a problem. So those patients would be ineligible. If they can't lay flat, they cannot get anesthesia, or if they have a rectal fistula, those would also be ineligible. Now here's a technique here. So number one, the equipment you need is a prostate operating room. So you could do anesthesia and sterile procedures. So on the top right is where you have a patient laying in a dorsal lithotomy position. You have an anesthesiologist who's giving sort of general anesthesia, or you could do spinal anesthesia. And you have an ultrasound machine. And you need to have stirrups where the patient can lay flat with an extended dorsal lithotomy position. You need to have a transrectal ultrasound that can go into the rectum. You have to have a template on top of the ultrasound equipment, and it has to be sort of step wide, and it has to be linked. So the ultrasound should be able to image in a transaxial and a sagittal plane, so you can get a three-dimensional placement map when you do this. The interstitial implant catheters that you're going to put has to be of a suitable design. And also these catheters that you're going to place should also be CT or MRI compatible, especially if you're going to do post-implant radiation dosimetry to figure out what the plan that you actually delivered, what it actually looks like. You need appropriate software to import the transrectal ultrasound or the CT or MRI images and be able to fuse those so you can take a look at the actual pre-plan and post-plan assessments. The software should be able to take those 2D slices that you generate with the transrectal ultrasound and convert them to a 3D plan. The HDR suite itself is where you're going to actually deliver the radiation. So you have to have an HDR suite. You have to have an afterloader, like in this case, a Radium 192. You have to have adequate shielding in the room, things like that. You have to have appropriate post-implant imaging with the transrectal ultrasound, CT or MR. So here's an example in the top right. You see the prostate itself, where the images were acquired in sort of an axial plane. And usually you'll put the D3, you'll see the sort of hamburger sign, where you put contrast and air mixture into the urethra with the catheter that's placed. So you can actually see that on the ultrasound itself. It's also called a hamburger sign, helps you actually visualize the urethra. So when you're implanting seeds, you're planting catheters, you're trying to avoid the urethra itself. You don't want them in the urethra. And the transrectal ultrasound is a grid, like for example in the bottom right, where it's mounted with the template and inserted at a 5 millimeter stepper, where the stepper ultrasound is kind of moving forward in the rectum, and you're getting images every few millimeters or so. And you can image all the way from the base of the prostate all the way up to the bladder and the base. And this basically allows you to generate a 3D plan. And you want to start out with needles on the top, like superiorly and anteriorly, and then kind of work way down posteriorly. Now, once again, here's an example of the needles being inserted. You want to use rigid steel or flexible catheter for insertion. The position of these needles are placed during the initial volume. The catheter is inserted in a predefined manner, typically on the top, because you're imaging from the ultrasound up. If you start from the top, you work down, you don't get the image distortions anteriorly. So it's better to start from the top and work backwards. It also allows you to see pubic arch interference on the top rows. The top rows is where you'll have more likely pubic arch interferences. You can kind of get a sense of that before you start. And you want to get good peripheral coverage of the glands. You want to start out peripherally and kind of work around. And then you want to kind of minimize posteriorly. So on here, you don't want this in the rectum. So you got to be very careful. So here, what you're seeing is the sagittal plane, where you can see where catheters are being inserted. Like, for example, at the top here, so you've got the base of the prostate gland here. And posteriorly, you've got the rectum here. So you want to kind of pay attention to the rectum and the prostate interface. And you can get this rectal wall, and you want to minimize any needles in that rectal wall. And the catheters themselves are placed 1 centimeter apart, and they're typically 3 millimeter peripherally to the gland, so you get a good coverage exteriorly. You can also put the needles deep into the seminal vesicles, and you can tell how deep you're going by, instead of doing axial slices, you can convert to a 90-degree, where the ultrasound probe can give you 90-degree, so you can look at depth, how deep the needles are going. You can also do, after the implant, you can do orthogonal x-rays to verify needle placement. You can also do CT scan or MRI scans. And on an MRI, T2 MRI will give you good anatomical detail, and T1 provides good reconstruction. So here's an example of implant, like here, and you can see like on the top on row, like, you know, on the like row 4, you can see where the needles are inserted. You can see these little white streaks going through, needle through, like the row 3, row 2. You kind of see that. And then D3 in the center is where you see the urethra. You want to avoid the urethra. And then you could do an MRI here on the right. You can see where the needles have been inserted, kind of these black dots covering the whole peripheral part of the prostate gland. You're at least 5 millimeters or more away from posteriorly from the rectal wall. And then you can see in the center the urethra itself is spared. So CTV is basically the prostate capsule plus any microscopic disease expanded by 3 millimeters, and the rectum is your organ constraint you're trying to minimize, and you want to, you know, kind of when you're treating the urethra is from the bladder base and about 5 to 10 millimeters to the prostate apex. So those are the volumes you're going to contour as your organ constraints, and then also your CTVs. You want to spare the rectum and the urethra are the main one, and optionally you can also include penile bulb, bladder neck, or neurovascular bundles if you want. So, so there's 2 ways to do HDR. One is to do it after external beam radiotherapy, or to do it as monotherapy. So most people do it as boost. So with boost, most people have done external beam radiotherapy doses with 45 grade, 25, 46, and 23. But if you look at randomized control trial, the randomized control trial that I presented typically did 35.7 gray and 13 fractions, and others have done 37.5 and 15 fractions. So just pick what works for you. A lot of what we do is 35.7 and 13, followed by a HDR boost. And then when you do the HDR boost, there's many options. In the randomized trial, it was 17 gray in 2 fractions, which was 8.5 gray per fraction randomized control trial. But at Emory, we do a lot of 15 gray in 1 fraction. So this is kind of what we use a lot, but you can use any of those options that works for you. And now this is the more common based on high level evidence, but there are institutions that are starting to use HDR monotherapy alone without external beam. So that's something that could be done, you know, on a study. But if you feel comfortable, you can probably do it on protocol. There are people starting to do this monotherapy alone, and there's different regimens out there. At Emory, we use 26 gray in 2 fractions, 1 week apart. So that's another option you have. You know, so you got to do this implant twice, at least 1 week apart. However, there's long-term data with HDR monotherapy is not well known, but there is increasing use of this across various institutions. These are the constraints per the GEC-ESTRO guidelines. So pre-implant, you're trying to limit your rectum D2cc below 75 gray EQD2. Urethra, you know, D0.1 cc below 120 gray, D10 below 120, and D30 below 105. And the post-implant quality, so after you've implanted the patient, you're going to do a quality assessment scan and read and generate that to get an idea. So what's an acceptable implant is when you have D90 grade, 90% of the volume, the 90% of the dose is being delivered more than 100% of the volume that you've sort of defined. So that's a good quality implant. Your PTV V100 should be at least 95% of the planning dose. And then heterogeneity, you don't really want a lot of homogeneities in there. So you want no more than 50% of the prostate gland getting more than 150% of the dose. So that's considered a good post-quality plan. So with that, I will stop.
Okay, thank you, Professor Frank, for this useful presentation. First, I would like anyone, the chairperson, would like to comment on Dr. Frank's presentation. So for the sake of time, we're going to proceed with the second presentation. I'd like to present Professor Mohamed Kouyazi, Professor of Clinical Oncology at Alexandria University. So we'll be talking about technical aspects in intracapillary brachytherapy for endometrial cancer.
Here, I would like to thank my professor and my colleagues for mentions for inviting me to present today the technical aspects of intracavitary brachytherapy for endometrial carcinoma. As we only know, the endometrial cancer is one of the most common gynecological malignancies of the women. Most of the patients presenting at old age, most of them more than 60 years. We have classical two types of endometrial cancer, endometrioid type and non-endometrioid type. Today we'll try to cover the inoperable endometrial adenocarcinoma. As we know, the fetal staging of endometrial cancer is a surgical staging, so we mainly depend on the surgery. If we have stage 1, the tumor confined to the uterus. If stage 2, the patient has invasion to cervical stroma. Stage 3, patient has positive lymph node, and stage 4, either locally invasive or metastatic. So the standard of care for management of endometrial carcinoma is a surgery, which includes total abdominal hysterectomy with bilateral salvage oophorectomy. So the external beam radiotherapy or brachytherapy or chemotherapy is based only on the individual risk criteria to reduce the risk of recurrence after the surgery. However, we have from 10 to 15% of patients with endometrial carcinoma presented with advanced stage, so it's not possible for them to do surgery upfront. Or general condition of this patient at time of diagnosis may not be optimal for performing the major surgery. Another scenario involves the presence of the severe comorbid conditions such as cardiovascular problems, pulmonary disease, or morbid obesity that make the surgery difficult. In this setting, the radiation therapy, chemotherapy, or brachytherapy can be used as alternative to surgery or before surgery. How we can evaluate the patient? As we know that staging of endometrial cancer is the surgical staging. So we need to do some of clinical methods for the staging. So we have what is called clinical staging for endometrial cancer. What is the clinical staging of endometrial cancer? We define the patient. Stage 1, the tumor only provides the uterus. Stage 2, tumor involves the uterus and cervix. Stage 3 has parametrial involvement and nuclear of vagina, but confined skin to ovaries, and stage 4, either not invasive surrounding structure or metastasis. This is clinical staging. Based on what? Based on number 1, complete pelvic examination to determine the disease strength, cervix or vagina disease, rectal and bimanual examination, or to some of imaging like CT to exclude the constructed intraoperative pickup and design the depth of myonuclear invasion, and also DIPSI to identify the presence or absence of any para-aortic or the pelvic nerve. So the treatment of inoperable uterine cancer, most of existing information regarding the treatment is come mainly from this retrospective study. We don't have randomized trials that compare surgery versus not surgery. So we have three major types of treatment for inoperable cases, including radiation therapy, chemotherapy, or combination of radiation surgery and interval surgery. So the different types of radiation therapy can be used alone as definitive surgery, especially for patients with comorbid conditions and disease limited to pelvis. And we have different methods of radiotherapy, either external beam alone, or brachytherapy alone, or combination of them. One study suggested that multimodality therapy is used for early stage disease, and two studies include 100 patients, ages between 39 and 80 years, and all patients received either external beam with L-Vertebretry or intravertebretry alone or combination. And it was 5 disease survival for combination usage, and the overall survival was more than 80%. Another study also used the National Cancer Institute surveillance that includes almost 1,000 patients, both the stage 1 and 2, who didn't undergo the surgical treatment, and the 97%, 39% received radiation therapy alone, external beam, or brachytherapy alone, or combination of the type of radiotherapy in this trial didn't appreciate any difference in overall survival or in specific survival. So now we can see it as chemotherapy alone or brachytherapy in any stage, stage 1 or 2. Regarding the brachytherapy alone, one study reported successful treatment of 45 patients with low risk and operable stage 1, small tumor, grade 1 or 2, tumor less than 2 centimeters, and less than 50% of invasion, with use only brachytherapy will get more than 90% improvement of the clinical complete response, and also improvement of overall survival, reaching to up 97%. Another study also reported high successful treatment of the patient with the brachytherapy alone. So brachytherapy alone can be used for stage 1 or stage 1 and 2. American Brachytherapy Society also reported improvement of survival with the type of the brachytherapy. We found the survival with brachytherapy alone is something like 70%, with the combination of both is 82 for the patient with a stage 2. So the difference in range of survival in this trial of the reported from the variety of the study and also unavailability of the use of the MRI. So what is the clinical situation for the high-stage brachytherapy for the cancer? Number one is insertion technique. The patient was brought into operating theater and all received spinal or epidural anesthesia, and the patient placed in lithotomy position to be able to do this technique. Then urinary Foley catheter was inserted and fixed against the bladder neck after the filling of the bladder balloon with the 7 millimeter of gadolinium if we use the MRI. Also bladder was emptied and then filled with saline. We do clinical examinations and under anesthesia, and this should be included. Number one, inspection and then speculum examination to assess the vaginal wall and the infiltration of the cervix, palpation to assess any residual tumor if this patient received external beam, and also transrectal palpation. The uterus should be sounded and the length of uterine cavity is measured, with then followed by serial dilatations of the cervix with the Hager dilator. With the presence of Foley catheter, we can also use the ultrasound to assess and to help for guidance of the endocervical canal and also to evaluate the placement of uterine applicator. In this study, okay, for example, this example of the ultrasound that can be used during the brachytherapy application. Here we can assess the wall thickenings in the different levels. We can assess the thickness of anterior wall, posterior wall, fundal height, muscle thickness at fundal, and also the cervical wall. Depending on the length of uterine cavity and topography of vagina and the cervix, as evaluated, the length of the curvature of uterine applicator which was chosen. We have different form of uterine applicator. We can also use single tandem with ovoid or vaginal cylinder. We can use what is called the triple tandem applicator with or without vaginal cylinder, and we can use what is called modified hymen capsule. And this is form of modified hymen capsule. We can use 3 or 4 and then connect it to the cervical ring, and then also we can use what is called rotor endometrial applicators, and we can use the vaginal applicator with the vaginal cylinder with the intrauterine tandem. And it's very important with a patient with uterine cancer because our target is the uterus. Is very important to treat the whole uterus. So it's very important for you to select the special tandem length that's able to place the tandem to reach to the fundus of the uterus. Once the applicator present in the place, we can do, if we don't have any vaginal cylinder, we can do backing. But if we use a vaginal cylinder, there is no need for backing. And then we can do planning. Either we can do X-ray to identify that the source is present in good position, and also we can use MRI or CT for planning. The patient has either one insertion with a multiple fractions or patients has with at least 6 hours in between, or it has multiple fraction with one fraction per insertion. We can repeat the CT imaging if we do one multiple fraction per insertion to be sure that the tandem not perforated or there is only applicator movement between each fraction and the others. Regarding the American Brachytherapy Society guideline for high-dose rate brachytherapy treatment of endometrial cancer, they recommend the use of MRI. If not available, use CT for volume-based approach for brachytherapy planning. The panel recommend the contouring of the CTV. This is a gross tumor volume CTV, which is on T2 weighted, the visible, any visible abnormality if present. We have clinical target volume that can be possible to be contoured on MRI or CT, and this clinical target volume include entire uterus, cervix, upper to 1 centimeter of vaginal, and the organ at risk can be contoured on MRI and CT. So the GTV is only contoured in MRI, however, CTV and organ at risk can be contoured in both MRI and CTV. And this example of the one patient with intrauterine hymen, as we see here that the hymen present inside the uterine cavity. So our clinical target volume, which is present in the green, the small green area, the tumor in uterine wall. However, CTV includes the whole uterine body and adjacent cervix. American Brachytherapy Society for high-dose rate for inoperable endometrial cancer, if the patient has stage 1 endometrial cancer, should receive at least 48 gray for brachytherapy alone, and at least 65 gray if the patient receives combination of the both external beam and the brachytherapy. GTV is possible to receive more than 80 gray. The dose prescribed within range shouldn't be exceed the parameter for normal risk. What is the parameter for normal risk? The T2cc of the sigmoid and rectum should be limited to 70 and 75 gray. However, the T2cc of the bladder should be limited to 80 and 100 gray. And this, for example, we just based on example of one patient, 51-year-old patient with adenocarcinoma of uterine cavity. Patient has a stage 1 beam. The tumor located in posterior wall of the cervix. If this patient received 50 gray with external beam, followed by 2 fractions of the brachytherapy, 7 gray in 1 fraction. The pre-treatment diagnostic workup for this patient include transvaginal ultrasound, MRI for tumor localization, and this MRI at times of the diagnosis, we see here the tumor present as posterior wall of the uterus and in close relation to the cervix. And this patient underwent brachytherapy using modified hymen with the ring applicator, and this is MRI at the time of the brachytherapy showing good response for external beam, and only we have just a small tumor present as a posterior wall of uterine cavity. And we do delineation of the volume. CTV is uterus, GTV is only tumor and organ at risk, bladder, rectum, and the sigmoid. And also we do planning of this patient, that the patient receiving 7 gray in 2 fractions. So the summary of the dose, patient should receive external gray 1.8 in 28 fractions, 50 gray, and then followed by brachytherapy, 2 fractions of 7 gray, and the GTV can be D90 can be reached to 99 gray, and the bladder T2cc it should be less than 90 gray, and the T2cc of rectum should be less than 70 gray, and also of the sigmoid. Thank you. خلاص السؤال.
شكرا دكتورة نعمات على البرزنتيشن. انا كان لي بس سؤال لحضرتك دكتورة نعمات، سؤال في حالات البوست اوبراتيف يوتراين لو use cylinder application
تمام.
if rectal constraints not covered, can you accept to change the margin 5 mm margin we add
معلش الريكتا
في حالات السلندر ابلكيشن
كادجفنت ثيرابي يعني افتر اوكي.
المارجن usually ب 5 mm all around. Would you change the margin if the constraints not applicable?
هو احنا actually الادجفنت الادجوفانت فاجينال سلندر بيعتمد على حاجتين، لو البيشنت بياخد براكيثيرابي الون او البيشنت بياخده افتر ذا اكسترنال بيم راديوثيرابي. لو البيشنت بياخد براكيثيرابي الون احنا بنسكرايب الدوز الدبس اوف 5 ملم، ده لو انا مش بستخدم 3 دي بستخدمها فقط 2 دي بلاننج، بريسكرايب الدوز at 5 ملم واكشن البيشنت will receive 7 جراي تايم 3 or 6 جراي تايم 4. وعاده الاورجن ات ريسك نوت اكسيد ان البيشنت didn't receive external beam. لكن لو انا بعمل بقى موديفايد بلاننج بعد اكسترنال بيم، او لو انا عندي مثلا في سكار او الجزء بتاع الابر فاجينال كبير، فبعمل عاده سي تي بلاننج. السي تي بلاننج بعمل عليه او ام ار اي، بعمل كونتور اوف ذا اور سي تي في تارجت بتاعنا وبعمل بريسكرايب للدوز اون ات. وبتبقى برضه نفس الكونسترين، الدي 2 سي سي shouldn't be exceed 70 جراي، بس 70 جراي come from external beam and brachytherapy.
بريبريشن ما بيبقاش تمام، يعني احيانا بتلاقي فيها حالات كتير بتلاقي ريكتال دوز عاليه جدا.
هي لو اول فراكشن يعني ممكن اصل 70 جراي دي توتال فروم 3 فراكشن، فممكن جيف ذا دوز وفي سكند فراكشن احاول البيشنت تبقى جود بريبريشن واقلل الدوز تو ريكتم، لان هي بتتحط على شيت والشيت ده هو اللي بيديني في النهايه الكالكوليشن بتاعت الدوز.
تمام، شكرا.
Another question, please, Dr. Nahat. You mentioned at the beginning that the 5-year survival for cases treated with radiation alone without surgery goes up to 70% in some cases and sometimes goes to 80%. So do you think it is possible radiotherapy alone can replace surgery?
ما اقدرش اقول الراديو ثيرابي الون كان بي ريبليس، ان هو ستيل ستاندر اوف كير هو السيرجري. احنا بنتكلم البيشنت كان نوت دو سيرجري، انا ما فيش عندي راندمايزد ترايل لو البيشنت فيت فور سيرجري اجي ادخله سيرجري ولا ادخله راديشن ثيرابي الون. لغايه دلوقتي انا ما فيش عندي ريزلتس لترايل كده، فانا بستخدم فقط الراديشن لو البيشنت دي ان اوبربل، لان زي ما قلنا المانجمنت بتاع اليوترس مينلي ديبند اون سيرجري حتى الستيجنج غير السيرفكس.
ممكن مثلا ترايل ان احنا ندي just radiotherapy and if there is residual disease we can do surgery. لو ما فيش disease you can keep patient observation.
في بعض الاحيان لما بتبقى البيشنت الاوبربل او عندها مشكله مثلا سيفير بليدنج ومش هينفع تعمل اوبريشن دلوقتي، ممكن ندي نيو ادجفنت سواء راديشن ثيرابي او كيمو ثيرابي فولود باي سيرجري، بس ما تبقاش الدوز ديفينيتيف، تبقى الدوز ممكن اكسترنال بيم الون.
I have a question for you.
شكرا يا دكتور.
First, thank you for this very good presentation. Second, I just ask about when you prescribe external beam radiotherapy for high risk endometrial cancer patient, if when they underwent formal pelvic lymphadenectomy and you have one positive lymph nodes only positive out of the formal or even multiple, how can you solve this situation? You prescribe external beam radiation for all the patients who underwent formal with high risk disease, formal lymphadenectomy, pelvic lymphadenectomy.
هو البيشنت دي اللي معاها بوزيتيف ليمف نود از ستيج 3 اندوميتريال كانسر، فانا اكشولي هيمانج ان انا اديها هاد كيموثيرابي ان ذيس، سواء ان انا اد 4 سايكل اوف ذا كيموثيرابي فولود باي ذا راديشن، اور ان انا ممكن ادي زي ساندويتش تكنيك 3 وراديو ثيرابي و 3، وبيعتمد ملي على اللوكال ديسيز. لو انا عندي مشكله راديشن بدي هول بلفيس عادي، لان البيشنت اوريدي عامله ليمف ادينكتومي، ما فيش عندي جروس ديسيز، اللي انا هدي سي تي في بس. مش ده سؤال حضرتك؟
هتدي اكسترنال بيم ولا مش هتدي؟
في الحالات اللي فيها بوزيتيف ليمف نود
عامله فورمال ليمفادينكتومي، سي في عندنا 10 lymph nodes remove one only positive lymph node او even negative وشي has high risk disease.
هاي ريسك من حيث ايه الكاركتر؟
هاي ريسك كرايتيريا، هاي ريسك
هاي
ريسك يعني
ما هو الستيج 3 في كذا مانجمنت، ان ممكن ادي كيمو ثيرابي الون، ممكن ادي كيمو ثيرابي فولود باي اكسترنال بيم راديو ثيرابي، او ممكن ادي 3 راديشن 3 سايكل حسب الريسك ديسيز. لو انا بيشن فور اكزامبل عندها سيرفايكال انفولفمنت اوف ديسيز، عندها واصل للور يوتراين سيجمنت، ممكن ادخل البراكي ثيرابي، ممكن ما ادخلش اكسترنال بيم، ممكن ادخل براكي ثيرابي بس.
يعني الحد بتعدي فقط على الستيج ولا على الريسك كرايتيريا؟ يعني
الريسك كرايتيريا الريسك كرايتيريا بعالج لو انا بتكلم على ستيج 1 ديزيز، سواء بقى انفيجن ليس ذان ماي هاف اوف ماي ميتريال او مور ذان هاف. اوكي، الريسك فاكتور انا بعالج بيها لو هي البيشنت ديت ستيج 1 بقول لو ريسك او انترميديت ريسك او هاي ريسك. according to criteria. وريسنتلي European Gynecological Society EGOS عملت molecular classification تاني، يعني بتعمل العيانين بول ميوتيشن الاول وبي 53 وام ام ار، وعلى اساسه بقسم البيشنت الى لو ريسك وانترميديت ريسك وهاي ريسك. ده في العيانين ال ستيج. لكن واتس ان الستيجنج بقى ستيج 3، انا مش بعالج على الريسك كرايتيريا انها لو ريسك ولا انترميديت ريسك ولا هاي ريسك، بعالج ستيج 3 فيها ايه؟ ستيج 3 هل فيها ادينكسيا؟ هل فيها باراميتريم انفلتريشن؟ هل فيها بوستيف لينف نود؟ طب البوستيف بارا اورتيك ولا بيلفيك لينف نود؟ حسب كل حاجه، لان ستيج 3 ده زي كوكتيل كده من الحالات، مش حاله واحده بس.
بالنسبه للنقطه دي احنا كنا عندنا في عين شمس، كنا بالاتفاق كمان مع الدكتوره هدى، كنا الموضوع ده اثرناه كذا مره. وبعدين يعني وصلنا حطينا يعني شفنا الاسجو جايد لاينز دي، كانت الدكتوره هدى هي اللي كانت يعني نمشي عليها، لان كان في عندنا الاسجو جايد لاينز وفي ام سي ان جايد لاينز. فحسب الاسجو جايد لاينز اتفقنا على التاني. ستيج 1 كلهم بنديهم جاست brachytherapy unless العيان ده يكون عنده نيمفاسكولار انفيجن، اكستنسيف نيمفاسكولار انفيجن. في الحاله دي بنديله external beam radiation alone، مش external beam radiation followed by brachytherapy، لان الان سي ان كاتبين في الحته دي external beam radiation and or brachytherapy. وانا ناقشت كذا واحد في الموضوع ده فقالوا لي لا هو مش and or،
هي الليمفوفاسكولار فعلا انديكيشن للاكسترنال بيم،
هي اور بس. بالنسبه للستيج 2 لازم اكسترنال بيم راديشن بلس براكيثيرابي. بالنسبه بقى للناس اللي هم هاي ريسك ستيج 3 4 في كذا الجي او جي عملوا كذا ترايل في البورتك ترايل، الجي او جي 258 لسه برضه بنناقش قريب، عملوا مقارنه ما بين البراكيثيرابي براكيثيرابي كونكوميتنت كيمو راديشن فولود باي براكي فيرسس كيموثيرابي الون، ولقوا ان مفيش فرق بين الكيموثيرابي الون والكونكوميتنت كيمو راديشن فولود باي البراكيثيرابي. لكن اللوكال ريكارنس كان اكتر في الكيموثيرابي الون، كان ديستانتاسيس قل في الكيموثيرابي الون. فهو في الحته دي لسه فيها ديبيت، هل يدوا كونكوميتنت كيمو راديشن فولود باي كيمو باي براكي، ولا يدوا كيموثيرابي الون فولود باي مثلا براكي او اكسترن بيت راديشن. هي دي لسه الجري زون اللي احنا مش متاكد منها. دكتوره غدا زي تحب تفهم
النقطه دي في عندنا الكورتكس.
Thank you very much for this very comprehensive talk covering all aspects of endometrial cancer. I'm just going to reply about this query about the case that you've put down is someone who's had a lymphadenectomy, and on the lymphadenectomy there was a positive lymph nodes. Rightly so, this patient is high risk, and therefore you would probably give radiotherapy, but you're not going to boost the nodes because the nodes don't exist.
Exactly.
So that's absolutely fine. That's absolutely fine. Yes. So despite the lymphadenectomy, this patient can have radiotherapy afterwards, after being consented about bilateral lymphedema and so on. Just going back again to the ESGO guidelines. So yes, I've directed the team here to follow the ESGO guidelines. They're very comprehensive guidelines, and they do merge the poly mutation, the P53.
Exactly, P53.
Sometimes you can find that someone who's with stage 1, we would normally just give external beam radiotherapy or brachytherapy only. But because they're P53 mutant, they're actually P53
mutation.
And in that case, you would give the full whack. You would still give external beam radiotherapy. You can give chemotherapy as well because of their
وده actually answer question why the patient with low risk who didn't receive any treatment develop recurrence. Because this patient maybe have P53 mutation.
Yeah, so now we can actually look back at our patients where we find low-grade cancers and stage 1s where we normally wouldn't give them even adjuvant brachytherapy, and then they recur. But actually it's because of some mutations that they had. Now we realize what's happened. I can refer everyone actually to the ESGO guidelines, and actually I have done a simplified flowchart which is published in the same journal, a simplified flowchart to follow in terms of which classifications, who gets what, because the ESGO guidelines can sometimes be too rich to follow, and
there's exactly
their table. So the color coding is exactly the same as well. I have just one question for you, and actually not just for you, for all brachytherapy experts here, because you've mentioned inoperable endometrial cancers. And the inoperable endometrial cancers, because of usually they're very obese patients, have got lots of comorbidities, as in cardiac and so on. I find it very difficult to actually subject those patients to brachytherapy afterwards, because rather than having a single shot of surgery, whilst they have one anesthetic, you're actually subjecting them to 2, 3, or 4, again with spinal. And one of the things that you've mentioned as well, and I've argued this with Estro, with Jack Estro,
Yes,
because it's on their guidelines. But actually, if you keep the patient lying flat, and they say, well, actually put the insertion once, and then every 6 hours give them a treatment, then you're increasing their cardiac risks and increasing their death risks from PE.
Actually, when I have this patient that's revealed from our gynecological, this patient is medical inoperable, I asked them to represent this patient again for high anesthetic team. I asked the professor of anesthesia to see if this patient and the cardiac patient and they get consent that this patient is not operable, because sometimes I found that the patient after receiving external beam trying to do epidural anesthesia said that no, the general anesthesia is good for her because the spinal anesthesia maybe do rapidly high potential, and this will be dangerous for this patient.
Yeah, and sometimes actually that once you've done the anesthetic assessment, you can go back to the surgeon and say, well, actually, I've done the anesthetic assessment. By all means, go ahead and operate. And actually, one of the things that you've mentioned, Professor Ihab, is about once you've given the radiotherapy and you've got a small residual disease, and you had the plan before to give intrauterine brachytherapy. In fact, what's going to happen is that probably if you restage the patient and get the anesthetic assessment, you'll find actually this patient can be operated upon. So that's it. You don't need to subject yourself to brachytherapy for her.
Exactly.
Yeah. But thank you very much.
Thank you.
Very, very good case. Thank you.
I have a comment, please, Dr. Purwai, regarding the question for stage 3. Okay, for stage 3, for the stage 3 cancer of uterus, according to the trial from the Portage 3, some of the patients will benefit from the concurrent chemoradio and brachytherapy. Okay, so it's not the issue now is to give chemotherapy alone. Okay, for stage 3, you have to go for sandwich technique, combine chemoradiotherapy, then followed by adjuvant or neoadjuvant chemotherapy.
كده فوق كده تحت.
GOG 258 قرن بس. هو البورتك ترايل قرن اول ما بين concurrent chemo radiation followed by brachy versus external beam irradiation. فطلع ان concurrent chemo radiation followed by brachy is superior عن pelvic radiotherapy alone. جم السكند ستيب GOG قرن ما بين concurrent chemo radiation followed by brachy versus chemotherapy alone. ولو ان مفيش فرق في السرفايفل بين الاثنين، لكن البلفيك ريكالنس كان اكتر في الكيموثيرابي، والديستنت ميتاسيس كان اكتر في الراديوثيرابي. فقالوا ان الموست اوف ذيس بيشنت داينج فروم ديستنت ميتاسيس، وبالتالي قال لك فالكيموثيرابي فكان يعني زي النصيحه ان الكيموثيرابي has the upper hand possible to be followed by radiotherapy. وفي بعض الاحيان ممكن اكستند بيم راديشن وممكن نضيف له brachytherapy، لكن دي كانت الستادي ديزاين كانت كده.
The main aim of the radiation here is to maximize the local control. The main aim of radiation is to maximize the local control as much as possible. For such cases, that's why the radiotherapy is important in stage 3 also.
Okay. Okay, thanks for the beautiful discussion. Now on to the next session. I'd like to present Professor Huda Booth, Professor of Clinical Oncology in Bristol University. She will be talking about the challenges of intracavitary brachytherapy in cervical cancer.
Thank you very much for inviting me. I hope the sound is all right. Thank you very much for inviting me to my home university, in fact. So I'm just going to, hopefully this talk is going to be a much simpler and actually mostly with photos and pictures and opening more discussions. Thank you for everyone who's chairing, and thank you for organizing that all these eminent brachytherapy professors are in the room. So hopefully all the discussions will be quite profitable for everyone. So I'm Hoda Booz. I'm an oncology consultant in Bristol. I do mentoring to several departments, and currently I'm mentoring the team in Egypt. So I was asked to give the talk about challenges in brachytherapy, and I've seen that most of the talks today have actually covered, before me and after me, the complexities. So I thought I'm just going to go through a few scenarios that we have been exposed to, and I'm open to comments. So development over the years, I can't start my talk without starting, as in developments over the years in terms of brachytherapy. It's a very simple thing. Those who are as old as I am probably have seen with brachytherapy starting that this has started as a 2D technique in terms of its planning. So the clinical oncologist would go into theatre, put the intrauterine tube, 2 pulpostats or a ring. In fact, the ring didn't exist that time early on, and then do just an X-ray film, like a simulator film. And with that, they can prescribe for brachytherapy. And the aim was to prescribe to a point called point A here. And that point A was supposed to be the maximum extension of the cancer. And point B used to be reported. And this gives you an understanding of how much the parametrium and the pelvic nodes have taken in terms of the doses at that point. And it was a very geometrical procedure without any CT scan. No ultrasound guidance was even existing in theatres. So it was a very simple way of planning. However, you wish that all cancers come as one shape, and they never do. So if you apply the point A and point B, you'll find that the point A would probably lie somewhere there, and therefore your prescription dose, that pear-shaped, definitely would miss those lateral extensions of the cancer, and therefore it doesn't cover it. Like with all the developments in radiotherapy, as in your planning with radiotherapy, with external beam radiotherapy in head and neck, in prostate, in planning in terms of the in gynae, IMRT started, and well, actually 3D planning started first, and then IMRT started afterwards, and the concept for planning was very different. So gross tumor volume as where the tumor is, the clinical target volume where the GTV is, plus any area that you think might have microscopic cancers, and the planning target volume. This is what we all know about IMRT and VMAT in any type, anywhere in the body. In brachytherapy, however, you wouldn't get, or you wouldn't use planning target volume because there shouldn't be any movement errors. So actually planning target volume does not exist. And all you're concentrating on is the gross tumor volume and the clinical target volume. So a very simple way of the real life of where us as gynae clinical oncologists would be experiencing. This is a patient that would present with a new cancer diagnosed. So this is an MRI scan, a sagittal MRI scan, and you can see the extent. And this is not uncommon that you see the patient presenting to you with a huge cancer involving the bladder, involving into the rectum, and such a huge cancer. And in fact, in that point, you keep thinking, well, actually, I'm probably going to give a very complex brachytherapy. I might not be able to treat this patient. I think all of us have seen these scenarios where you think, oh my God, I'm not sure what I'm going to do when the time comes for brachytherapy. And then you give the patient the concurrent chemoradiotherapy, 5 weeks, 45 gray and 25 fractions, together with weekly cisplatin chemotherapy, as we all do, I'm sure. And then you find that the result is like this. So actually, the patient had a near complete response, no residual disease, or maybe a small residual disease within the cervix. At that point, you would still give, obviously, you're able to give intrauterine brachytherapy. What I'm trying to get at is that brachytherapy is not always, when you've moved from point A to actually a 3D or a proper planning, image-guided brachytherapy, it wasn't just for the sake that you're trying to spread your doses to try and engulf this very large tumor. In fact, it was actually to try and minimize the doses that you would have given brachytherapy with if you're prescribed to point A. So if you look at here, so this patient, this is the same patient, would have had so this is an intrauterine tube. And at the time we were using colpostats rather than rings, so 2 colpostats in the vagina. If I would have given this patient point A dose, the point A would be 2 centimeters, sorry, the cursor is a bit difficult, so 2 centimeters above the central, the top of the vagina, and 2 centimeters across. So actually, your blue line would have been there. So you would have treated more of the organs at risk that you're concerned about than you should. So this, with image-guided brachytherapy, in fact, we managed to bring in the doses and save more of the organs at risk and lower the doses. Sometimes you're actually on numbers, you're still managing to get the doses fine in terms of the EMBRACE protocol, and it's actually well within. But why not even more? Why not even reduce it? Remember, this is the only, I think, the only cancer or the only treatment that when you're treating, you're not just thinking under your feet. You're not just thinking, oh, I hope her 3 months post-treatment MRI scan shows that this patient has had a good response. You always think, I need to know how this patient, 5, 10 years down the line, if she's free of cancer, she still have functioning bowel and functioning bladder. Most of these patients now are very young, and therefore you have to think about the long-term effects. And this is why the EMBRACE data are coming out in terms of the late toxicity. And I think the last speaker of this session is going to talk about the late effects. But it's very important that you always have this way of thinking. So I'm just going to say that I've mentored the team here in Ain Shams University, and thank you very much. It was Professor Ihab Mustafa, who was the head of department at the time, and I'm sure Professor Inan Sha'rawi will carry on encouraging the team that we carry on in terms of the brachytherapy. So this is the full theme, and I was very keen to put all the names, nearly all the names that were actually involved. And I'm putting it there just to show that when you're setting brachytherapy, it is not just simply the clinical oncologist. By all means, Ghada and Christine, you've done a brilliant job in terms of training for it. But actually, I was very keen from the beginning that we involve the nurses, so the nurse that's going to be in theatre. So they were in the team that when we were mentoring the whole team. The nurses, so 2 nurses, the junior and the head nurse for the theatre, also the physicists, other clinicians, so Mohammed Heba and Mohammed Darwish as well, because we always wanted a bigger team in order so people can cover for each other. The baseline for brachytherapy in terms of cervix cancer and squamous cell carcinomas, that you do not want gaps. So it should not be a single person that's going to be there. And a junior doctor, Hoda, who I'm hoping that in the future, training as a very young doctor, hopefully then, by the time that she becomes one of the seniors, she will be mastering the whole process. So actually all of them, and the physicists, so we had the physics team, we have, I don't know if they're there or not, but they're the senior physicists and 2 physicists as well. The more you widen the team, the more resilient it is going to be, because then you know that there is always someone there. And actually, even if they're, all of them are there, you've got 2 heads to think. Actually, I'm not sure what to do with this. Your colleague can tell you, well, actually, how about doing this? Just provocative in terms of thoughts and thinking about it. So thank you very much. And this is just a few of the pictures as well. So this is when I was doing the first procedure with the team, and this is the head nurse here of the theater, and Christine and Ghada there, making sure that everything is there. And this little nurse, Budur, who's a buzzing nurse, and the team, the physics team as well, with the head nurse, the head physicist, and the junior physicist as well. And this is all of us here when we finish the procedures. So back to where we were, and I'm just going to go through very simple ways of going through just sharing with you some of the challenges that we had. I have deliberately left that name here as infusion, although I'm the first person to say do not fuse images. And I'm going to say this why. So basically, the brachytherapy, image-guided brachytherapy, when it first started, it started as completely CT-based, which is absolutely fine. We all started with CT-based brachytherapy. In some centers, like the one I am in, I was fortunate enough to be very thick-skinned and insisted that we move all together to MRI, to the gold standard, all sessions with MRI. And this is where we're at. So we're doing in all sessions, we're doing MRI scan for each session. So patient finishes the 45 and 25, their 5th week, they have an MRI scan without the applicator in, just so that I prepare the team of what's coming. So whether I know if I needed interstitial needles, do I not need interstitial needles? Do I need a cylinder in theater in order to cover the lower extension of the disease? Do I not need it? So all these were possible to be done. So we do the week 5 MRI scan. And then when they first started, we did CT scan with each of them. I'm one of the first people to actually say that you should, I do not agree with actually putting one insertion and then treating the patients in 2 or 3 sessions with one insertion. Accuracy, risks with patient lying flat and developing PEs and so on is very difficult. So, and therefore they're very protective to having 2 sessions a week to be able to fit the 4 sessions in 2 weeks is a great idea. So with your first MRI scan, I would say do not fuse. If you do the CT scans with the IV contrast, probably you'll be seeing better. This is ideal, the MRI scan, but hey ho, not everyone have got the access to it. And I think we've spoken about access and the possibility, the difficulty in terms of wheeling patients from one place to the other. If you were fortunate enough to have a nice smooth corridor to be able to wheel the patient, that's absolutely fine. Going out in the road, no. I think this is, and quite, to be honest, quite humiliating as well for a patient who already had a very humiliating procedure. So we have to think about that as well. If you can do an MRI scan with 1 or 2 sessions, that's great, all and good. Even then, I wouldn't say that I would fuse the MRI scans with the other sessions, simply because the applicator is never in the same position, never. So the bladder is never the same fullness. The bowel is never the same shape. So do not do it. Definitely each session needs to have its own images to be done. So if we go past that, I'm just going to go through some scenarios of difficult situations. I've done a mixture of patients that were with cervix cancer and some of them that had a relapse without having a uterus. So patients had previous surgery. And I hope I'm not going to take too long. So first of all, so this patient here, and this is just to mention, when a patient started with a huge tumor of the cervix, so the posterior lip of the cervix, huge tumor, and this is the coronal, this is the axial and the sagittal on an MRI scan. So this was pre-radiotherapy, and on clinical examination, on examination under anesthetic, the vaginal walls were involved. So the vaginal involvement, wall and fornices were involved. So although the picture can tell you that actually probably middle third, in fact, clinically, it was the lower third of the vagina that was involved. So after radiotherapy, the patient had a brilliant response. And the reason I've put that here is that usually you would go in and say, yep, Ringham tandem or a tandem and colpostats would be absolutely fine, because all you're left with is this very small tumor well, not small tumor, bulky tumor, but in the cervix, but nothing like where we started. This is a typical patient that I've done the week 5 MRI. So this was post-radiotherapy, but during the 5th week of MRI scan. And I said, I do need the interstitial cylinder in this patient. The reason is because I needed to treat the full length of the vagina, because this patient I know that had previous involvement of the vagina. So these are one of the things. So I'm like you here, that you're a referral center, that you're having patients coming from different centers. You haven't seen the patient prior to the radiotherapy, but you can have the scans. And this is why I'm saying 1, 2, 3, 4. Very important that you need the pre-MRI. You need any details of any examination under anesthesia that has been done, because simply this patient can be undertreated by us if we didn't know that this patient had vaginal involvement. So in that case, we used an interstitial cylinder, and having the interstitial cylinder, this is the picture in. So you've got the intrauterine tube and the cylinder. The cylinder is multi-channel, and the actual needles are within the tumor that you can see. And therefore, when you do the distribution, the dose distribution, you can see here that you're actually treating the full CTV, high-risk CTV. If you had a ring and tandem, I bet you would have stopped there. And this is where you're actually, you would have stopped there. But actually, this is the visible high-risk CTV. So this is the visible, but the intermediate risk CTV, so I've outlined it in this patient, although I know we've talked about just growing it by a centimeter around the high-risk CTV. In some cases, like in this patient, I do grow it manually by hand in order to cover the areas that I can see that question mark that they were involved, that hasn't been involved after. And this is, this is again the other planning a session with it, so it's actually involving the rest of it. So, and this is the second case here. So this is a patient who had previous hysterectomy with no indication for adjuvant treatment, and came back with a relapse in the vagina. So the only area of relapse was there, no disease elsewhere. And so this patient has had the only chance that we treat this patient was with a vaginal cylinder. So the reason I've put this case here, because I've used the multi-channel cylinder, I can't remember what you call it here in your applicators, but this is a multi-channel cylinder without the need for intrauterine tube, because simply the patient doesn't have a uterus. And if you were to treat, so this is another image, but if you were to treat this patient with a single source, as in with a central source of rather than multi-channel, a 5 millimeter depth clearly is not going to cover. If you say, well, okay, well, I'm going to plan it, and therefore I'm going to cover it with the same single source. Once you've actually tried to cover the rest of this area, the high-risk CT, where the tumor is, automatically, because it's only one source, you're actually going to bow it to the other side and unnecessarily increasing the dose to other organs. And therefore, I wouldn't use that. What you would use is a multi-channel, because with the multi-channel, you can control that the channels that are close to the tumor can cover the area, but the other channels don't need. So actually, even I've managed to cool it down so that the patient doesn't have that extra dose. The patient was young, and therefore intercourse clearly we didn't need to think about that as well, that she, once she gets any vaginal scarring, it will be a very difficult thing. I'm just going to rush through this one because this is a very similar one as well, with a very similar situation, but because of time, I'm not going to go through it. But again, with the multi-channel, I would use for single relapse. Right, so this patient here is a typical one that was referred to us from another center. And because I meet with other centers weekly, but obviously virtually, and we discuss the cases that are coming to us. So we actually share the screens. And the clinician, before starting the external beam radiotherapy, asked me, what shall I do about this? Sorry. Sorry. What shall I do about this? So this area, this here area that you can see is a relapse above the vagina. Okay? This area here, so this patient doesn't have a uterus. She actually had a previous hysterectomy for something before about 10 years ago, and then had this relapse at the top of the vagina. And then you have this here is probably a parametrial lymph node. So she asked me, what shall I do about this? You're going to go in with brachytherapy in here. Probably if I boost this, it's going to be on your brachytherapy area. So bravely, I said, do not boost it, and I will do that in brachytherapy. But the surprise that happened is once she started responding, the two has actually got separated together. So I regretted my decision that I didn't ask her to boost it. But I had to do something, and I consented the patient very well about the risks with overdosing. This is not moving, I think. Oh, there it is. So what I did is I used, again, the multi-channel with the interstitial multi-channel, but obviously the patient doesn't have a uterus, and therefore I didn't put an intrauterine tube. And you can see here, I managed to track a needle within the recurrence and then into the node that can be seen here. And you can see it here as well. I wouldn't wish it on anyone. It was a very, very complex procedure. And I had the gynae team on standby in case I've done a disaster in theatre. Luckily, nothing happened. She didn't bleed, and it was amazing. But it was because there was a clear area between the two. To be honest, this is a typical one. I would never be able to do it without an MRI scan. With that accuracy, there is no way you can do it. So I had ultrasound guidance in theatre. We had CT to check the needles and so on. But then I went with the patient to MRI scan with all the kit ready to pull back any needles if I needed to, and it was fine. And this is another patient who, before radiotherapy, also had a large area of relapse at the top of the vagina. So this is a very similar patient to yours, medically inoperable. And so she was supposed to be treated in another center who do brachytherapy, but they couldn't anesthetize her. There was no way that she would have an anesthetic. So she had a previous hysterectomy ages and ages ago for a certain reason, but this is actually, she was in her 80s and had all the medical comorbidities you could think of. Her death chances with anesthetic was very high. So they've sent her to me, thinking in case that I could do it because of the complexity of it. I thought, so actually we couldn't give her even interstitial brachy. I can't give her an anesthetic or even a spinal. She was very, very overweight. So what I did with her in her situation is I've used a cylinder, multi-channel cylinder, very similar to the ones I've discussed with you in the team here, that you would do. I've put a multi-channel cylinder and agreed that the position is fine, MRI'd the patient with the applicator in, documented the length of the tube out of the patient, the height of it, and so on, took it out, and then the patient went home. Clearly, I would not make this patient wait until we've done the planning. And then we've done a very thorough planning with physics, again with MRI scan guided, and in order to cover the area. So you can see here at the top where the whole cylinder is a normal loading, which is fine. But here at the top is to cover that area that is right at the top. So you can see the blue line is the prescription line, and it covered the area of concern. And this patient, I'm glad to say, had a full recovery from it and actually had a complete response. The sixth case here, so this is a patient who's had a previous hysterectomy for a cervix cancer, and she had no indication at all for adjuvant treatment. Unfortunately, 18 months later, she presented with bleeding and abdominal pain and was found to have this huge disease right at the top of the vagina and adjacent to the sigmoid colon, so actually involving the bowel as well. The patient had lots of social issues. She refused altogether to have exentration. Typically, this patient would have had an exentration. She completely declined it. I've consented her about treatment. worrying that she may not respond because it was a very aggressive cancer. And I think she's had a scan a couple of months before this was diagnosed and there was nothing. So it just tells you how aggressive this cancer is. This patient had, pre-radiotherapy, this is how you can see how big it is, and involving the bowel as well, and involving the posterior wall of the bladder. So we've given her chemoradiotherapy, 5 weeks of chemoradiotherapy. Unfortunately, I was shocked to find that actually she still had the disease there, which is depressing. I had it discussed several times in our MDT, and I had the patient back, and we decided that we're going to go ahead and treat her. So I actually did an examination under anesthetic. To my shock, I hardly have any access in the vagina to actually put a ring, to put needles through it, or to put anything. So you either do it blindly or not. But I thought about something different. So this is our applicator with the intrauterine tube and the applicator with rings, where you could have the inner side and the outer side. And I decided to use just the little one here in order to be able to push it as far as possible in the vagina. And this is exactly what we've done. So you can see here, the full vagina, the vagina is completely scarred, completely tethered with the tumor to attach it to the bowel. So I put that here, the actual template, and put the needles here. And in fact, I have treated the bit of the bowel that's involved, because that's her only chance that we treat this. With the complete consent that you probably will have a colostomy at the end, because I'm pretty sure she's going to have scarring and intestinal obstruction. So this was the procedure. This was the planning. We managed to get a very good dose. But again, the bowel doses, the area that I've outlined is completely treatment dose. The rest of the bowel, the 2 cc, was up to the limits rather than the aims of embrace. So I took it higher up. After the treatment, at 6 months, still had, 3 months, still had quite significant disease left behind. And this is when I tell you that hands off, you've done what you can, you just wait and see. So this patient had the 3-month scan and it still had the disease, but she was feeling better, and it was shaving off the bowel slightly. And then 6 months later, shaving more and more off the bowel, but still there is residual disease, a little there, completely depressing, that you worry that this is all of a sudden is going to blow up as a disease. And then at 6 months, this is what it was. So complete response, but the bladder is completely attached to the bowel. But anyway, she was functioning, bowel fine and bladder fine. And at 12 months, she remained sustained complete response. And again, at 24 months, sustained response. So this patient started, so I can boast about it and say, I've treated her, that's fine, but this is what I'm saying is, think about, this patient was in her 40s, think about 10 years down the line, what's going to happen. So she's now 4 years off her treatment. No, all her MRIs are clear. And by the way, I follow her up with MRIs because there is no way I can examine her. She's completely scarred. Her vagina is completely scarred. No way I can examine her. But, or at least the top third is completely scarred. So what's happened with this patient is that she started having bleeding PR, and I told her she had a scope, and actually we know that there is no disease there. But I told her it's probably the radiation proctitis. Every time you're constipated, you will pass blood, and it was right. So she made sure she was always on sodium docusate, stool softener, and she doesn't get constipated, and she stopped bleeding. Only when she admits if she eats more fiber, she would. And then a year later, so at 3 years, she started having some blood passing per urine. Again, I thought, well, okay, this is radiation cystitis. She had a cystoscopy. It was absolutely fine. And we had repeated cystoscopies every 6 months, absolutely fine. But then her kidney function started going off. So I thought, actually, be safe, send her to the urologist. So the urologist, I called them, told them how complex it was. Unfortunately, so this is now 4 years, her ureter is the one that actually was in between all this, where the attachment happened. So the ureter was completely scarred, and this patient, her kidney, one of the kidneys completely failed. So actually, she's now recovering from a nephrostomy. Sorry, not nephrostomy, nephrectomy. So she's actually lost one kidney because of this. This is exactly what I'm saying about the long-term effects. Yes, it's a good thing she doesn't have cancer. And luckily, it happened in something that had, 2 kidneys, you've got another organ, so that's fine. But things happen months and months, and I'll keep following her up because I'm not in doubt that this, she might end up with different, and she is consented that she may need a intestinal surgery if, at some point, but her intestine is fine. Again, this is one of the cases that was only a couple of months ago. This is a mother of 10 kids. She's in her 30s. And she presented with a very large tumor here. And as you can see, the reason I'm actually describing this is because obviously this patient, you would have thought when you first saw her that, the brachytherapy is going to be very, very complex. But she had radiotherapy, combined chemoradiotherapy, just a very quick run through the EMBRACE GTV and the high-risk CTV and the intermediate-risk CTV in green, and also the CTVE, so the lymph nodes as well. So the patient was treated as per EMBRACE with all the volumes that you could think of, as in ITV, IRCTV, and so on. And also she had a boost in one of the nodes, and this lymph node, she had one single lymph node with all the size of tumor, only one lymph node was involved. So this was boosted to 57 gray because it was far away from the brachytherapy boost. And this patient, as you can see here, so if you would have looked at the sagittal images only, you would have thought, well, actually, I can do her with a ring and tandem with no need to do anything extra. She had a complete response, amazing and complete response. However, clinically, examination under anesthetic and on her sagittal and on her images here, you can see that she has a large cervix here. When I examined her, the cervix was completely engorged with blood vessels. You can see it in blood vessels. This patient at diagnosis, I forgot to mention, she was diagnosed with a hemoglobin of 4. She bled completely. She came through emergency. There was no diagnosis of cervix cancer before she came to us. So the cervix is completely engorged with blood vessels. I would not have dared to put any needles in her. So what I did the first fraction only, 7 gray to the high-risk CTV with a ring and tandem. Simple and easy. Done that, that's fine. In her second procedure, the cervix, as if you've given a hemostatic dose. So I'm fine now. But because of the big cervix, the ring actually does not cover the cervix. So in fact, despite the fact that she doesn't have any visible disease, I still used interstitial needles in her. So that's another use for the needles, because I need to cover the high-risk CTV. You're not covering the tumor, you're covering the high-risk CTV. So I've used needles, and in fact, I had to use even oblique needles as well there. And the cover was absolutely fine. This patient is, only just finished treatment, so I actually haven't done her 3 months MRI scan, but I promise I'll bring her back. This is my last case, I promise, but I've added her last night just because of the discussion that we had. So this patient presented with a large, she's in her 70s. She presented with a large tumor in the cervix, lower end of the cervix. She has 1 kidney, incidental finding of a 1 kidney. So I gave her chemotherapy, 2 cisplatins, and then I had to stop because her kidney functions shot up. Wasn't brave enough to give her carboplatin either. So I just carried on with radiotherapy only. And to increase the complexity, she's bicornate uterus. So she's got 2 edges of the uterus. Anyway, presented with a huge tumor in the cervix, as you can see, fungating and, a really impressive tumor. Again, had the brachytherapy, the external beam radiotherapy with the high risk, intermediate risk, and the lymph nodes, and then increased the volume for the IRIS CTV, the IRCTV, and then the planning target volume. So all was covered, absolutely fine, and it wasn't touching. It was actually involving the middle third of the vagina, but not the lower third. Anyway, so this patient, after radiotherapy, unfortunately, she still had the disease there. huge tumor, very big, but I took her to theatre to examine under anesthetic, and what I did with her is I've used the ring and tandem, managed to get the tandem within one of the cornets of the uterus, and this is the cylinder, sorry, not a ring and tandem, I meant a cylinder, interstitial cylinder, and used the needles in the cylinder, but also used the template, we call it the Kelowna template, which is the perineal template, and used 3 needles in the rest of it because the needles could not cover the rest of it. However, this patient does not have parametrial invasion. So all this cancer is filling the vaginal fornix. So I'm actually not going into the parametrium with her. So this is the coverage, and this is the coverage in terms of the brachytherapy. Post radiotherapy, in terms of the planning here, and this is my last slide. So you had, this is, sorry, did I put, yeah, so actually you can see it with the dates. So this is the 3 months post-treatment scan, and you can still see the disease there. I actually asked the surgeons to take her to theatre. I couldn't believe that there is still disease. They've done biopsies, and it was all necrotic post-radiation. But they couldn't shave it off. The reason is because it was attached to the vagina, and if they do that, they will end up with probably a fistula because of post-radiation. And this is, again, 3 months later than that. So this was, I think, November. This is April. And the tumor is slightly, or whatever, the residual lesion that I can see is slightly smaller. And again, still attached to the full length. We did another examination under anesthetic. No cancer cells, just post-radiation. Patients. And then the last, this was 4 months later, no disease at all. A late responder, simply a late responder. So she's now, off the records, but obviously will continue with her follow-up. And this is the end. Thank you very much for listening.
Thanks, Professor Huda, for this kind and valuable presentation. This just a notice more than a question. Would you recommend to include PET-CT for evaluation of the response of your patient, especially cases number 6 and number 8?
So the PET-CT is not for the response. So actually, this patient did have a PET-CT, but it's, to be honest, it's not for the response. I'm very confident with the MRI scan. It was because to exclude any evidence of distant metastatic disease or any lymph nodes, especially the last 2 patients, because it's a huge disease, and I couldn't believe that there is no distant disease, but it happens. Yeah.
Case number 6, that patient represented a very slowly response over time, over 2 years, till complete response.
Yeah.
I think if PET-CT, it will assure us that the SUV...
Again, the PET-CT, so the PET-CT was done, but also that this is the aim of the PET was not to check whether this is disease or not. It was basically to see if she's got any widespread disease, because I was holding my hands against giving her chemotherapy. Because, the other step here, there is nothing else I can do. The patient is declining radical surgery. She's really got a very complex social setup and adopted children and so on with autistic. So, she just could not face going to theatre. And have a radical surgery. So the only reason is for me doing the PET was to see if I needed to give her chemotherapy or not. But not actually for the sake of the response, no.
Dr. Huda, can I ask you? Thank you for your elegant presentation. My question about the chemotherapy after the brachytherapy. If you still present persistent disease and no response on the brachytherapy, you will advise the patient to receive chemotherapy?
No, only if there is metastatic disease. Only if metastatic disease. If there is residual disease, so if there is residual lesion and the biopsy
on external beam or brachytherapy, and you do MRI after brachy, we found stationary disease. You will not advise the
So this is exactly what I would, no, I would wait. There is a lot of late responders, even squamous cell cancers, not just adenocarcinomas. So I would wait. I wouldn't give them chemotherapy. I would wait and monitor. I think once they come to the point where it's a year and you can see that there is still something there, then at that point you could think, but actually I wouldn't do chemotherapy either. I'm just thinking what I would do, because normally what we would do then is probably even a simple hysterectomy. So you could actually ask the surgeons to do, they don't need to do radical, because obviously if they go out to the ligaments, you've frozen it all with the radiotherapy. But a simple hysterectomy might be an option.
Yes.
And I have done this, to be honest, since I've started giving, a very higher dose and doing MRI scans and managing, with the Embrace protocol and really pushing the doses high. I haven't done it, but before, because I was really fighting to get MRI scans before, if the patient had residual disease at 3 months, within 2 weeks of their scan, they would have a simple hysterectomy. And we've actually published this, me and the surgeons. Yeah. Yeah.
Thank you, Dr. Huda, for your elegant and impressive presentation. As usual, it's not new for us, of course. My first question for patients with cancer cervix, sometimes you are facing problem coming with subtotal hysterectomy with amputated cervix. There is no canal, parametric infiltration. So post-external beam radiotherapy, how do you manage your brachytherapy?
Sorry, so they had the hysterectomy.
But subtotal.
Subtotal, so they have cervix.
Amputated the cervix, half of the cervix.
Yes, yeah.
Yeah, so in such case, how do you manage your brachytherapy?
I would still use so if you've got access, you have to measure the actual length of the cervix. So we have, we're lucky to have, in fact, intrauterine tubes that are 2 centimeters. So you could use that together with the ring. The other option is using interstitial needles just for that area. So using the ring only with the cap for interstitial and using needles only for that.
So you consider it as like a stump?
As a stump, yeah, it is a stump. It is by definition.
Even these 2 centimeters you cannot find after surgery.
So in that case, the one, I think the presentation is gone, but so that the applicator that I showed you, one of the things that you can do is actually swap the inner ring with the stump that I used for the patient number 6, I think it is. So if I use the stump only, the bits in the middle, this is not for an intrauterine tube, it's for a needle. And therefore you're fully in control of how deep it can be.
Okay. A second question for patient, sometimes patient coming with uterine extension.
Intrauterine extension.
Yes. Especially, even more than half the endometrium.
Uterus, yes.
So in your brachy procedure, how do you consider this in your planning?
Again, with that, I would use a ring and tandem. And laterally, but the inner ring, if you put a few needles, 2 or 3 on each side, and push it higher up, but within the substance of the uterus, that helps the physicist to cover that. Yes, yeah. Or the other option is actually with the intrauterine tube, because it's within the uterus. So in fact, you can increase the dose because you're not planning to point A, you're planning by volume. So you can increase the hotness of the ring plus the intrauterine tube, and both of them you can bow the isodoses.
But do you do it as contouring as the CTV based on pre-extended radiotherapy imaging?
No.
No.
So the whole planning is what you ended up after 5 weeks of radiotherapy. The only consideration I have is the intermediate risk CTV. So if it was a huge tumor before, usually just growing the high risk CTV by a centimeter, you're covering it. And in fact, the teaching now with Embrace is that you do that. You just increase by a centimeter and you're done. But sometimes if I know that there was, the shape doesn't fit and actually there was more than that, I push it more just to make sure that at least 60 gray to the volume that was actually pre-treatment. But most of the time, you don't need it. Just a centimeter growing of the high-risk CTD does it.
Thank you so much.
Okay, thank you.
So, my dear professor, please let me thank you on behalf of the team of the Ain Shams University for accepting to be our mentor from the very beginning. Thank you for accepting and correcting our mistakes. Thank you for being that kind of mentor who is not only keen for the patient, but also for the team. Thank you very much.
Thank you very much. Thank you. Thank you.
Okay, thanks, Professor Huda. Now, I would like to present Dr. Professor Dr. Mohammed Abou Fatouh, Professor of Clinical Oncology at Northern University, who will be talking about the role of interstitial brachytherapy in cervical cancer.
أولا بشكر الزملاء في الاسم في عين شمس على الدعوة الكريمة. أنا حاسس إن المحاضرة دي كان المفروض تبقى قبل الدكتورة هدى، عشان هو ده الجزء الثيوري، والدكتورة هدى يعني إيه قامت بالجزء البراكتيكال يعني. Intracavitary brachytherapy is an integral part of definitive treatment for locally advanced cervical cancer. It's an elegant radiation delivery system that generates a classical pear-shaped isodose distribution around the tandem and vaginal source. It allows much higher dose in the central cervical region and rapid peripheral dose fall-off sparing neighboring structure. ان يبقى عندنا في السنترال فيري هاي دوز، لان دي اكثر حته فيها نيكروزس وهايبوكسيا and radio resistant region of the tumor. عشان كده ده بيبقى بيجاستيفاي الابروبنت ان احنا يبقى عندنا سنترال زون اوف هاي دوز. برضه بيشجع على كده ان احنا عندنا هاي توليرانس لليوترس والابر فاجينا. And I think the next session might discuss the tolerance of the upper and lower vagina in the part of the complication. However, sometimes you need to, in some situation, is not enough to do intracavitary alone, particularly if we have bulky disease, extensive lateral parametrial invasion, and lower surface vaginal involvement or unfavorable topography after radiochemotherapy. لو حضراتكم شفتوا الكرتون اللي موجود، السيتويشن الاولاني بيفت البير شيب ايزودوز لاين. احنا عندنا جوه السيرفكس وكفرد ويل في البارت بي من الكرتون. يو كان سي ان عندنا parametrial extension of the tumor that necessitate to do some interstitial needles in order to bring the dose to cover this area. The placement of intrauterine tandem along with interstitial needles combine the already established benefit of intracavitary brachytherapy and the flexibility of the interstitial brachytherapy. The enhanced target coverage and potential dose escalation to tumor provide the scope to improve oncological outcomes in local advanced cervical cancer. احنا عندنا several implant procedures. عندنا two approaches، يا اما الهايبريد modification of intracavitary application زي الرينج with interstitial needles، او زي الفينيسيا ابليكيتور زي ما هنشوف بعد كده، او يبقى عندنا بيرينيال تمبلت زي المارتينيز وزي السيدنبلت. دول يا اما انترستيشال الون او بعمل الاثنين كومباين مع بعض. ده اكزامبل للرينج ابليكيتور، عباره عن الرينج بيمر فيها الكاستر اللي بتعدي، وعندي الفتحات للنيدلز بقدر اعمل. مشكله الرنج او ان انا ليميتد بالسايز بتاع الدايمتر بتاع الرنج. احنا عندنا مثلا السايز 26 مللي 30 34. فلو انا عندي حاجه اكستند بره الرنج مش هقدر اكفر كويس، ومحتاج برضه ان انا اعمل انترستيشال نيدلز بره الرنج. في ابلكيتورز تانية نقدر نستعملها. ده المارتينيز ابلكيتور، في زيه مارتينيز عندنا في البروستات، وده للبلفكس، ده اللي هو اليونيفرسال بلفيك انترستيشال ابلكيتور. زي ما احنا شايفين كده عندنا obturator في النص، وعندنا الاماكن الفتحات بتاعه النيدلز، وبقدر اعمل زي الامبلانت اللي احنا شايفينه على الشمال. The use of tandem, which is the backbone of intracavitary dosimetry in the with perineal interstitial, is inconsistent practice. Tandem may provide several advantages to the perineal interstitial brachytherapy implant. It helps strengthening and stabilizing the uterus for the subsequent placement of needles. It addresses the superior intrauterine extension of the tumor, which can't be accessed adequately with straight and rigid interstitial brachytherapy needles. And Dr. Hoda nicely showed several cases with tandem and interstitial needles. It forms a high-dose region in the cervix where more resistant tumor cells may result. It was demonstrated there is clear survival advantage of placing tandem and increasing dose to 0.8 in patients with stage 3B. Also, there is decrease in the rate of local recurrence. This study showed that when you combine intracavitary with interstitial, you have in the panel, in the A panel, you can see that there is improving in local control, and also in the other one, you can see that there is increase in disease-free survival when you combine both together. This is the applicator what we use for interstitial. We have this ring applicators with different lenses of tandem, and we use this plastic needles, which is called blue guide needles. We use it for interstitial. And this is a case where we have parametral extension to the left side. We have these needles, and we managed to increase the dose to cover the high-risk CTV with 3 needles inserted in the ring. This is another case where we have extensive, again, left parametral extension. We have the needles inside the ring, and we managed to do freehand 2 needles in the parametrial. So we have covered the high-risk CTV with and keep the tolerance of the organ at risk within the tolerance. This is the case where we have this thick scar at the top of the vagina. We have this. We have a ring, and we managed to do interstitial needles. We have 3 needles on each side, and we covered the 6 thumb. We can't do this with ring alone or cylinder. We can't get this height without needles. This is what is called the Venecia applicator. It combines all the types of needle you can imagine in gynecology. It has this semilunar which can form a ring with needles in the ring, and also have oblique needles that can give radiation to the distal parametrium. Also, we have this perineal template, so you can do insertion through this template. You can see here, this is how you can mount the template together. You can see here this on the left hand side, the oblique needle which can go to either side or anteriorly or posteriorly, so you can increase the dose if you have anterior extension or posterior or lateral with this oblique needle outside the diameter of the ring. So this applicator allows treatment of patient with stage 3B cervical cancer, but also you can use it for stage 1B, all stages with this applicator. One applicator can treat multiple tumor stages, so you can use the same applicator type for various patients group. Interstitial brachytherapy for advanced stage cervical cancer can be performed with free hand. Also, although the Veneza still allows freehand needle placement, is not necessary because they have parallel and oblique needle holes in the ovoids, and perineal template guides the needles to the desired location. This is example for a case treated with this applicator. You can see here anteriorly, we managed to increase the dose anterior to cover the high-risk CTV with this applicator with using the oblique needles. And this is the case where we have a lower vaginal extension. We couldn't get it to cover the posterior vaginal extension with the cylinder. We have 3 needles, freehand needles. We put it just below the area where we have, and we managed to get this isodose line, and we nicely avoid the rectum. So intracavitary fractions are typically delivered 1 to 2 times per week. For template-based interstitial implants, the entire treatment is commonly done during one insertion, given the complexity involved with proper placement of brachytherapy catheters. Fractions may be delivered twice a daily, separated by 6 hours, with the total brachytherapy course delivered over 2 to 3 days. This is the recommendation for organ at risk dose limit, and I think it has been covered before. Before starting implantation, you need to give some antibiotics, and it was found that the incidence of perineal skin infection is lower when you use prophylactic antibiotics. This is a treatment setup consideration because this is a complex treatment and error prone. You have to need to make, should have a robust quality assurance. A specific error related to gynecologic interstitial brachytherapy can include discrepancy between the catheter number labeled in the implant diagram and the catheter numbering in the treatment planning system, incorrect lens measurement for one or more part of the applicator, wrong dose or dose combination with external beam radiation, applicator slippage between treatment planning and treatment delivery, shifting of needles from their intended position over the course of multi-day treatment, variation in organ at risk positioning over the course of multi-day treatment. My take-home message, brachytherapy is a necessary component of definitive radiation therapy for cervical cancer. Intracavitary applicators may not provide the necessary dosimetry. Interstitial brachytherapy allows anatomic access and the potential to customize dosimetry to encompass the clinical target volume and reduce those to normal surrounding organ. And thank you.
Thanks, Professor Abou Futuh, for this kind presentation. And to who didn't know, our Professor Abou Futuh, he is our mentor in Menofia University, and he is the founder of Brachytherapy Unit in Menofia and actually in Delta. My question for you, my dear Professor, situations that we can use ultrasound guided freehand needles.
احنا عندنا مشكلة دايما في ال MRI is not available all the time. So mainly we use CT, and we have insulator, we have the MRI, we have the ultrasound guided. So with needles, as you were part of this, we managed to do it freehand under ultrasound guidance. If you can see the case, one of the needles come in contact to one of the other, very near to one of the needles in the ring. So we omitted that and used the other two. it is not perfect, but this is the best we have at the moment. So
Thank you so much, Professor Muhammad, for your nice presentation. The question is for some patients after extended beam radiotherapy, 46 or even 50 gray, you find poor geometry that allow proper intracavitary application. So in such a case, do you go directly to intracavitary and interstitial, or do you, and especially with extensive parametrial post fixed subpelvic wall?
So you can use, sometimes if the vagina is very narrow, you can't even introduce a ring or ovoid. So you can use this interstitial template, transperineal. But the problem is you will keep the applicators as I mentioned. Okay.
Thank you very much. It's very, very thorough, actually, coverage to the whole process. Just answering the question or commenting about it, that I personally wouldn't use perineal templates for all interstitial needles, even if I can't get the ring in. So if you can't get the ring in and you're going to use the template, it's only to hold the needles in place. The problem we have, and I don't know about your templates, but the problem we have is that if you have the template and you put the needles in, you have to put the needles through the template, and therefore you can't actually see very well. So the template is actually, this is what it's made for. It's only to be used if you're doing like a vulval implant or a perineal implant, so someone with extensive disease that has gone outside. This is what it's made for. It's being, in a way, overused exactly for these situations. But my recommendation would be that you put the needles, free needles, and if you have a needle collector, just to put the needles in place, as in hold them, or not hold them at all, but as soon as you put one needle, then you actually label that needle, because remember, this is not in a template. So if you're in that position that you can't put the ring in, then in that case, and you're using free needles, this is what I would say. But I think this is a very, very cautious spot. You know, this is a very dangerous procedure. The free needles don't always go where they should go, even if you've got the ultrasound there. The beauty about having a template like the ring is because it's a thick one and it's got a hole from the inferior and superior, then it's directing it so it doesn't diverge. But if you use a free needle, then because of the firmness of the tumor, it goes right and left. And it's not always very easy to detect it by ultrasound. Remember, the ultrasound is a plane, it's like a plane. So actually your ultrasonographist, who is going to be sitting there, will be trying to find you. And it's very, very tricky. It's not the easiest. So I think in very, very complex situations that I would use it, I wouldn't use it. Can I just comment about something as well? I know you've mentioned here that putting an insertion and then doing multiple treatments on one insertion, and then the problems that you mentioned right at the end, I think you'll find that there are 3 or 4 items related to that procedure, is actually putting one insertion and doing multiple on it. One thing that you have to remember is, you know, when you're doing it, and I'm sure you'd agree with this, is every time you do the patient, you find that you're doing it better. So if you do the first insertion, and you consider that you're going to sit the patient in and repeatedly treat the patient on that one insertion, sometimes it's a bad insertion. Sometimes you find that actually when you've imaged the patient, or I wish this needle was so and so, or I wish I've done this, angled it more. So you're stuck in that situation. You're stuck.
The problem is we are obliged to do tests because of the anesthesia.
Yes.
We don't have anesthesia every day, so we do Monday and Tuesday. We
Yes.
do the first insertion on Monday and keep the applicator overnight and then do scanning in the morning and give the second
I
session.
think you'll find that most centers who do the multiple insertions, if you really quiz them about it, because even in Jack Estro, a lot of them actually do that. But if you quiz them about it, they're not happy about it. They're actually doing it because of exactly the same limitations. Access to theatre. So some of them do not have access to, most centers have their theatres as part of the general theatres. This is an awful setup. But you know, what can you do? You just do it as you can. A lot of the centres in the UK have the same thing. If you have your own theatre, then you really need to do two sessions or two sessions a week and make sure that they're spaced as you're doing. But this is why we've put our foot down that actually we needed a room for treatment rather than a theatre in the procedure within the department. But exactly because of that reason, and having the anaesthetist, dedicated anaesthetist, to come and do it, because otherwise you're stuck, and it's not just the application. It's the patient risks for patients with developing pulmonary embolism or bleeding, pain, even being on top of the pain, applicator moving and how you're going to be accurate in it. Multiple images within 2 or 3 days. How many CTs will you do in order to make sure that the bowel hasn't moved or the bladder is the same fullness? So, yeah. Thank you.
Thank you so much.
Okay, thanks, Professor Mohammed.